Hello, and thank you for joining us. My name is Bonnie Baker. I'm the Executive Director of the Canadian Lymphedema Framework. And on behalf of the CLF, I'm excited to welcome you to episode 2 of Pathways Live, Authors in Conversation. This series brings some of our magazine's most compelling articles off the page and into real-time conversation, like a book club for lymphedema care. Each episode features the author of a selected Pathways article. Before we introduce our host and our guest author for today's live stream, we have just a couple things to share with you. Prior to joining us today, you were provided with digital access to the reading materials, including the article that we'll be discussing. You can find a direct link to these materials in the live stream chat, should you wish to reference them during the conversation. You've all found your way here, so we hope you have a good internet connection and a nice quiet place to enjoy the live stream. But if you should get disconnected for any reason, please know that the session will be recorded, and a link to the recording will be shared with you via email after the live stream has concluded. I'd like to take a moment now to acknowledge the generous support of our industry partners whose sponsorship helps the CLF to deliver great programs like Pathways Live to you. Thank you very much to Bauerfeind, to Juzo, Essity, Medi, Waries, Lymphology Skincare, Sigvaris, and LNR. Now, without further ado, I'm pleased to introduce the host for today, Pathways Editor-in-Chief, Anna Kennedy. Anna is a CLF founding member and the editor of Pathways, the CLF's official publication. Anna spent 30 years in corporate senior management, working in the areas of training and communications for international companies like Thomas Cook and American Express. Her last business role was as vice president with Indigo Chapters before she transitioned into the charitable sector in 2006. Anna served on the board of the International Lymphedema Framework from 2012 to 2020 and was the CLF's executive director from 2014 to 2019. She currently volunteers in an advisory capacity to the CLF board on project-related activities. And I should say that Anna was awarded the Queen Elizabeth II Golden Jubilee Medal for her leadership and contribution to the lives of Canadians. She lives in Toronto, Canada, and advocates for healthy living and a positive attitude for living with lymphedema. I'm very proud to introduce you to her now. Oh, there she is.
There I am.
Just switch us around there. Hi, Anna. Welcome. We're very excited about today's session. I'm going to turn it over to you.
Great. I'm very excited as well to be the host of this Authors in Conversation series. My role as editor-in-chief of the magazine means my work is primarily remotely and online, coordinating author submissions, editing and writing online for preparation of the production of the publication. But rarely do I get to speak live with others involved in the magazine, except for our quarterly editorial board meetings. So this is a unique opportunity to connect key authors with our readers as well. Today's topic and article for discussion focuses on dispelling myths about lipedema and discussing the paradigm shift supported by scientific evidence. Promoting education based on evidence-based research is very dear to my heart. It's one of the pillars of the Canadian Lymphedema Framework and the basis for the magazine. I don't want to minimize the important role that others had in earlier research and clinical guidelines for the lipedema community, but as science evolves, it's imperative that new research findings be adopted and integrated into best practice guidance. I'm honored to introduce Dr. Tobias Bertsch. We first met at the National Lymphedema Framework Conference in Dallas way back in September 2012. We shared an informal dinner table with Dr. Jay Granzow and casually talked about nutrition and weight control. I was still eating non-fat yogurt for breakfast, and Tobias convinced me to add more fat and protein to my breakfast so I'd feel more satiated until lunchtime. I still follow that advice to this day and sometimes think of him when I reach for my daily yogurt. I was impressed by that first presentation I heard from him at that conference and made a mental note to invite him to a Canadian event. It was Montreal, Quebec, 2017, and he was very gracious considering what a perfectionist he is, because we had frustrating technical challenges that happened at the podium. It all worked out in the end, but I remember the stressful time. However, I'm confident that today, with Bonnie and Grace quietly working the technology part behind the stage, today will be a smooth event. We appreciate his busy schedule at the Foldy Clinic, and with a 6-hour time change, the time that he has taken for us today. Dr. Bertsch is the medical director and chief physician of the Foldy Clinic. European Center of Lymphology in Germany, specializing in lymphedema, lipedema syndrome, and obesity. He's the founder and past president of the International Lipedema Association, the world's first and only professional association in this field. The members of the ILA are exclusively health professionals. From 2016 to 2019, Dr. Bertsch also served as Secretary General of the German Society in Lymphology, and in 2019, he was a Congress President of the German Congress of Lymphology. He's the leading author of the article series, Lipedema, Myths and Facts. These articles have spread worldwide and contribute to an essential paradigm shift that we currently see in the diagnosis and treatment of lipedema. Furthermore, he organized the first International Lipedema Forum with distinguished experts in this field from 23 nations. Together with renowned psychologist Gabriele Ehrbacher, Dr. Bertsch also is lead author of the International Consensus Document on Lipedema, which was published in October 2020. This consensus is supported by renowned experts and key opinion leaders from 23 countries. In 2012, Dr. Bertsch earned Specialist Certification of Obesity Professional Education, the only international recognized certification in obesity management for healthcare professionals. Furthermore, he's a certified obesity expert at a national level. He developed a unique multidisciplinary therapy program for patients with morbid obesity, obesity-associated lymphedema, and lipedema. This very successful program includes bariatric and plastic surgery when indicated, in addition to conservative treatment. Dr. Bertsch is one of only 2 physicians in Germany who consult in an outpatient setting of a lymphology hospital, meaning that patients with suspected lymphatic diseases or lipedema can be examined and treated in the outpatient setting. He and his team treat approximately 7,000 patients, inpatients and outpatients per year. Dr. Bertsch lectures extensively throughout Germany and around the world, including several times in the US and Canada. Please join me in giving Tobias a very warm Canadian welcome. Hello there.
Hello, Anna. Thank you very much for this wonderful introduction.
It's a long one.
A very long one, yeah. I was really surprised when you recently asked me for this interview, and I thought, wow, 5 years have passed since that article, how time flies. And yeah, we have achieved a lot in that time. Really,
yes,
yeah.
An awful lot. It's really nice to connect with you on this call. In order for our audience to get to know you a bit better, can you spend 2 minutes sharing what a typical workday looks like for you within the Fulde Clinic?
At the Fulde Clinic, my day usually starts at 7:30 in the morning with a quick handover from the doctor who was on call overnight, since we see a lot of severely obese patients with lymphedema and with lipedema, often with other health problems on top. It's not unusual that there are emergencies to talk about first or other problems. We will talk in the morning. At 8 o'clock, I jump into my outpatient clinic. There I see patients who have been at the Fulde Clinic, so for follow-up, and others the majority come with unexplained swelling after cancer surgery or other surgery, and it's my job, or because of obesity or other causes. And it's my job to figure out the diagnosis and set up the right treatment. And because the topic of lipedema, our topic today, has become so popular in recent years, and it seems to get more and more attention every single year, I now see patients with suspected lipedema every day. And it's interestingly, about 80% of them actually turn out not to have lipedema at all. And the same numbers are published now from the Charité, from the University of Berlin. My outpatient department, the clinic runs until 3 p.m. And after that, I usually have meetings, catch up on administrative work. And later in the day, I go through the new admissions. Together, we have every day between 10 and 20 new admissions. I go together with the ward doctors and we discuss the treatment plans for those patients.
So after that busy day, and on weekends? What are 3 things you like to do when you're not working?
When I'm not working, 3 things. That's tough because there are definitely more than 3 things I enjoy when I'm not working. And first of all, I love spending time with my partner and with friends who are important for me. Sports also play a big part, especially tennis and running. You know, we both of us play tennis. That was one of our first conversations we had in Dallas at that time. I also read a lot, mostly books with historical background, and I'm really passionate about traveling. This spring, for example, I went hiking in Patagonia with my older son, who is 22. He's also a physiotherapist, by the way. And that trip was something very special for me, not only because of the beautiful landscape of Patagonia, but also because of the shared experience with my son. That was something very special. And I have to admit, I actually enjoy preparing my lectures. It's in the evenings after work with a glass of good red wine. And I hope that's something people can sense when they hear not the glass of red wine, but the fun I have while preparing my lecture.
Yeah, and I do remember, other than tennis, that was the other thing we shared, because it was over a nice glass of red Merlot, I think, that we had at that conference. So It's been 5 years, as you mentioned, since we had that article on in Pathways on lipedema, and we interviewed you at that time about that new European consensus that was recently published in 2020. However, your work in that area started long before 2020. Can you briefly outline some of the steps you took to get to that point in the European consensus?
Yes, I don't know, Anna, maybe give me one remark, because you showed that this picture, this cover. I don't know whether you noticed that this issue of Path was very special. You know, it's not because of our interview, but because of, do you know this article in which you wrote, which you spoke very openly and personally about your lymphedema. I reread this article a few days ago again, and I just, like 5 years ago, I was very impressed and moved. I really moved by your journey and into the world of lipedema. All the viewers here, I can recommend this article of Anna, and the situation for patients with lymphedema has certainly improved significantly in the last 20 years. Awareness of this disease is certainly different. Patients usually receive diagnosis and therefore treatment more quickly. And you, Anna, have certainly played a huge role, a huge part in this improvement through your work. As Bonnie already said, your time as an executive director of the Canadian Lymphedema Framework, and now for many years as an editor of Pathways. So thank you for that.
Thank you. I didn't even realize that. I'll have to relook at that was the same issue that my article was in.
Yeah, yeah.
It was also 5 years ago. How time flies.
Definitely. So back to your question. So it started really 10 years ago when I took over the outpatient department at the Folder Clinic. And back then, more and more patients, or women being referred to me with a diagnosis of lipedema. And to be honest, I was quite unsettled at first, because all of them were being treated in exactly the same way as patients with lymphedema, with complex decongestive therapy with CDT. But when I examined them, I couldn't actually find any relevant edema or lymphatic problems. Even with high resolution ultrasound, there was no fluid in the tissue. And yeah, that made me start questioning things. I began giving talks, discussing whether lipedema should be really treated like lymphedema. And I realized that many colleagues were having very similar experiences and thoughts about that. And in 2018, that's what you already told, I launched a 5-article series called Lipedema Myths and Facts, and which attracted quite a lot of also international attention. And of course, not everyone, I have to say that not everyone was happy about it, of course, but that was the first step. And the same year, with the support of Jobst, by the way, they gave me great support. I organized the first European lipedema forum together with colleagues from 5 countries, the next year with 7 countries, and at the end in Copenhagen, we were 23 countries and founded the International Lipedema Association. And in 2020, the international consensus were published. So that's really how this whole journey began, with questions, with doubts, and with the wish to understand and help my patients better.
Well, it's become it's obviously received worldwide recognition. It's not only a European interest, and that's shown in the number of people, both health professionals and patients. Even on the call today, we have over 175 participants from many, many different countries, not just Canada and the US.
Yeah.
So you spoke about the common myths that needed to be dispelled. That was what the interview in the article was about 5 years ago.
Yeah.
I know there's a lot of other questions we want to address as well, but maybe we can briefly walk through some of those myths. So the first one, that lipedema is primarily an edema problem or a lymphatic disorder. Can you outline that? I know there have been quite a few published studies where ultrasound, MRI, ICG were used, finding that lipedema patients have normal lymphatic function.
Yeah, this is the biggest myth, that lipedema is a edema or lymphatic disease, but that simply doesn't match what we see in practice. Not just me, but thousands of experienced lymphologists worldwide. You already mentioned that we had at the international forum, which lead then to the International Lipedema Association, what we founded in Copenhagen. We had many renowned experts from Australia, from the United States, from Europe. So it was really international. And in the meantime, we not have only the experience. You also have a lot of study, large multi-standard studies with high resolution ultrasound or MRI. Couldn't find any fluid in the tissue of lipedema patients. And when researchers look at the lymphatic system itself with techniques like ICG or which is a special contrast agent, or 3D imaging with Viper, they found completely healthy lymphatic vessels in patients with pure lipedema, which means patients who don't have lymphedema, pure lipedema. Even histological studies show normal lymphatics. And this was really clearly stated in the national consensus published 2020, and it's been echoed by many colleagues, including the Professor Hugo Bertsch, one of the legend of lipology, who said in his foreword, lipedema is neither an edema. Yeah, this is the foreword what you show here from Hugo Bertsch, who sadly died in 2023. He said lipedema, there's a quote from him, is neither an edema nor lymphatic disease. And just recently, the new German lipedema guidelines published in 2024 and endorsed by 10 major scientific societies in Germany, and they have adopted this view and also this quote from Hugo Bertsch. So what I find especially encouraging is that the Völde Clinic, which is Europe's leading center for lymphology, has already been working according to this new concept since 2020. So no patient with lipedema in our center will treat it with MLD or with decongestion. So the paradigm shift is really happening step by step. The myth that it's edema or lymphatic disease is being replaced by scientific evidence.
That's great. And the next one is that the next myth is lipedema is a progressive order. So learning that lipedema is not progressive should be positive news, correct? Like that should be encouraging and comforting for those living with lipedema who assumed it would just get worse as time progresses.
That's a great message, because a lot of people who are informed by social media, for example, they are scared that it's progressive, but there is no evidence to support this claim. In fact, we have very good studies in the meantime showing the opposite. Let me mention one from Isabel Farmacodeo. She's also a renowned lipedema expert from Spain. She published data showing that about 2/3 of patients remained completely stable over many years, patients with lipedema, because their weight remained stable. Now, about 1/3 of these patients in the study of Isabel, they experience worsening, but that was linked to weight gain. And of course, if someone with lipedema or also without lipedema gains 10 or 20 or 30 kilograms, their legs will become larger, just as men tend to get it around the belly. And that's not lipedema, I guess. But in this case, or in that case, it's not the lipedema is progressing, it's the obesity that's driving this change. And by the way, together with my colleague, Gabriele Eberer, you mentioned, she already in your introduction, I will speak at misinformation in lipedema at the ILF-ILA conference at Niagara Falls in 4 or 5 weeks.
Yeah, not far away.
Yeah.
But so it's not considered progressive, but it's still considered a chronic disease, no? Even if it's not progressive, or would you say not?
It's a chronic disease because there are no really tools or therapies to cure it. I know that surgeons who perform liposuction promise, or many of them promise, that it's cured after that, but that's not data-based, and that's not what I see every day. But what I see sometimes is when patients suffer from obesity plus lipedema. For example, a patient with 120 kilograms. Do you have pounds or kilogram in Canada?
Kilogram.
Kilogram, okay. The same in Germany. So let's say if the patient has 120 kilograms and she's getting bariatric surgery after or gastric sleeve, and she will lose weight 40, 50 kilograms. Then we see really often that she has no pain anymore and almost normal legs. And these patients, then we call it lipedema in remission. So these patients, they don't have lipedema anymore. But yes, we can say it's a chronic disease. But it's definitely not a progressive disease.
Yeah. What is the link of lipedema and mental illness? I mean, one of the myths was that lipedema causes mental illness. I know you have a different
Very good point. Yeah, that's another myth we wrote in this article. That's another claim, and you can hear it quite often in so-called scientific articles, but also over social media, that lipedema makes women mentally ill. But if you ask, is there any evidence for that? The answer is no, Anna. The answer is no. The studies that makes this claim basically asked patients with lipedema whether with questionnaire mostly, whether they had a psychological disorder like depression, anxiety, or eating disorder, PTSD. And the majority of patients said yes. And then the authors concluded lipedema causes depression, lipedema causes mental disease. But this is a classical case of confusion, correlation with causation. Let me give you an example. In 1964 in Hamburg, it's a big city in Germany, in Hamburg, an unusually large number of storks were sighted. And at the same year, an unusually high number of babies were born. I think we all understand that storks and babies are not directly connected, because the correlation is not causation. And we at the Völde Clinic did, a few years, I think 2021, we did a study which was published internationally together with Gabriele Eberer, with 150 patients randomized study. And we looked at psychological conditions such as depression, anxiety disorder, eating disorder, PTSD, stress levels, and independently of when the lipedema pain started. And what we found was striking. In almost all cases, the psychological issues were already present before the onset of lipedema symptoms. In other words, not lipedema is the cause of these mental problems. That said, we do know that psychological stress and high level of emotional burden can strongly influence the perception of pain. And this is something my colleague, the psychologist Gabriele Eberer, will be discussing in much more detail at the ILA conference. And by the way, also there's a Harvard Medical Symposium in next February, where we both will speak about also these topics. I will speak about obesity at the Harvard College, and Gabriele will speak about the psychological connection with lipedema. By the way, the last studies in both oncology and rheumatology have shown that stress or psychological strain can actually heighten the perception of pain. So that's not a lipedema typical phenomenon. That's also in other problems that stress, psychological problems increase the pain perception.
Right, right. On to the next. Lipedema makes you fat. So my question is, have you seen patients in your clinic who have lipedema and are thin or of normal weight? Is that uncommon? Or can you explore the myth lipedema makes you fat?
Of course, but both questions. These are two questions. Let me first respond the second question. Yes, there are women with lipedema who are normal weight. But if you look at the published numbers, the proportion is clearly below 10%. And in our experience at the Völde Clinic, it's certainly below 5%. So they are rare. Yeah, there are, but they are rare. And your first question, or the myth you asked for, lipedema makes you fat. Now, the idea that lipedema somehow produces fat cells on its own, sorry to say, strikes me and frankly, it's wrong. Fat cells are, maybe every one of the audience will remember of your biology lessons at school. Fat cells are, after all, nothing more than energy stores filled with triglycerides. For all these stores to increase or for new ones to form, there always has to be an energy plus, more consumed than expended. Anything else would violate the first law of thermodynamics, which is beyond dispute. I think everyone would agree to that. But what is true, so, is that men and women differ in their fat distribution. Men tend to accumulate fat in the abdominal area, women around the hips and legs. And in lipedema, this typical female pattern is how do you call it? Exaggerate? Is it English? Exaggerated? Yep. Exaggerated, yes, thank you. With a striking emphasis on the lower body. So the condition does not change the overall energy balance, but it does shift the distribution of fat within the body.
Okay, yeah. So this next myth is related to that. Does that weight loss has no effect on lipedema?
Yeah. This myth also contradicts both the scientific data and more than 20 years of clinical experience. Losing weight and especially keeping it off, it is a challenge for everyone, men, women, with or without lipedema. And traditional diets don't work. Weight Watchers, keto, low carb, low fat, all this stuff, which is, we have a lot of ads, particularly in the springtime. They fail. Not the patient is failing, the diets fail. And what I think healthy food, what you mentioned in your introduction or when you spoke about your breakfast, about your porridge and high yogurt, yeah, and I do the same, by the way. That's the basis. But what's really help if you have really overweight, if you're obese, are these new weight loss injections, such as semaglutide or tirzepatide. Have you ever heard about that?
Mm-hmm.
Yeah. So that's the brand name is Wegovy for semaglutide, and Mounjaro, at least in Europe, is Mounjaro for tirzepatide. And these are really game changer in obesity medicine. And what is even more effective is, of course, bariatric surgery. And we recommend patients with obesity and patients with obesity plus lipedema the bariatric surgery if the BMI is around 35 or 40. When a patient loses weight, she will, of course, also lose fat in the legs.
Yeah.
Why should it be any different there? And in this way, she can also benefit with respect to her lipedema. And most patients report fewer symptoms, though not always completely. Others report, as I said a few minutes ago, that there is no pain anymore, so we call it lipedema in remission. Compression stockings often remain necessary, and physical activity should definitely be continued. I will also speak about that in this is my topic at the lunchtime symposium at the ILF conference. So for people who are interested in obesity and lipedema, Anna Towers, Günter Klose, and I will speak about that topic very in detail at the lunch symposium there.
So you mentioned bariatric surgery. One of the myths here is that liposuction leads to a marked and persistent improvement in lipedema.
Yeah, that's what social media and the surgeons always claim, but we have no scientific data to support such bold claims. In fact, Anna, the only studies available have been conducted by those who perform liposuction. Mm. So from my perspective, when I'm very open, frankly, not sure how politically correctness or how politically correct I have to be. But from my view, there's a strong overlap between economic and medical interests here. Maybe you know what I mean.
Yeah, so there isn't any independent data right, from these surgeons.
I'm not against liposuction. In my view, liposuction can certainly make sense when conservative therapy has failed, and conservative therapy, I mean proper treatment with compression, exercise, weight management, psychological support, education, self-management strategies. If all of this fail and the patient has significant symptoms, then liposuction may be considered. However, the patient should not be obese. She should not be experiencing major weight fluctuations. Is it English?
Fluctuations. Yeah.
Yeah.
They need to be steady, right?
Yeah, but should have a certain certain degree of weight stability. Why? Because if she goes through constant yo-yo dieting, then after liposuction she will regain weight, and the effect for the procedure will be rendered meaningless.
Yeah.
So that makes no sense for me.
Yeah.
I had 2 days ago. I told that colleagues I had a patient. She had a BMI of 60, which is, in my point of view, she came to my OPD. She said she suffered from lipedema. She already had 6 liposuction with a BMI of 60. This is not medicine, Anna. In my view, this is a crime. And between the first and the 6th liposuction, she gained more weight again. She regained more weight than the liposuction surgeon removed. So this has nothing to do with serious medicine, in my view.
Yeah. I'm going to skip, and I'm going to do a couple of questions before we about the process, before we actually address some of the really great questions that have been submitted ahead of time or during this interview. So just 1 or 2 more questions before we get to those questions. How has the new consensus been incorporated into clinical practice, and how can North American clinicians, health professionals, and everyone else on the call, whatever country you're in, what can they do to facilitate that knowledge transfer to make sure this new consensus is adopted into clinical practice? Because there's a long way to go, right?
Do you mean now, particularly North America? What North America?
Yeah. So sorry, I have confused the two questions. So the first question is how in Europe, how in your practice, how have this new consensus been incorporated into clinical practice? I mean, are all therapists outside of full D clinic? Are all health professionals in your country adopting this new paradigm shift and adjusting their day-to-day treatment guidelines, diagnosis and treatment?
That's a good question. But it's difficult to respond. I think in the area where I live, it's quite popular, and I see many patients or many colleagues who work in this way. Yeah. At the Folder Clinic, we adapted the international consensus already since 2020, and we have an interdisciplinary concept to work with these patients. And I also know from other hospitals like the Charité in Berlin, which is the second large center, they also work with this approach. But it's difficult to say how many, or for me, how many of the physiotherapists. I think many physiotherapists still perform MLD because they told me it's easy to do. And yeah, maybe there are also sometimes economical reasons to do that. But at the conferences I organize, we receive a lot of positive agreement about that. I think, and more notice that the scientific data are very clear. Yeah, I think when there is no edema, when there is no lymphatic disorder, and the scientific data are really overwhelming here, what is the job for MLD? Why decongestion? Yeah. So right. I think it's growing. The acceptance is really growing in Germany, at least.
Yeah. Well, I mean, the scientific evidence is growing, and it's education and information that basically changes things. So today's interview is one of those articles, help with that. Also the conferences that you speak at. And Grace, if you can put up, there's also some visuals of publications that Dr. Bertsch has provided, and those will be sent to people afterwards as well. So we encourage you to read those scientific articles and take a look at some of the other materials that will be given to you after today's event. So I want to go to some of the questions, some of the practical questions for many of the health professionals on the call today. So I'm going to focus first on compression therapy. So what's the most common compression level for lipedema, and is flat knit more suitable for containment, or is circular knit sufficient?
So in my view, a class 2 compression is talking about, that's about 25 to 30 millimeter of mercury. That's completely sufficient, and together with physical activity, most of my patients experience clear relief from it. And depending on the shape of the legs, legging, or even just knee-high stocking plus capri. You say capri? You say capri to the capri trousers, or panty, or how do you call it? Yeah. So it can be enough, which many patients find more comfortable, especially during the warm summer months.
Right.
And they can wear only knee-high stockings. Yeah.
Yeah. But do you use flat knit more than
only flat knit? Only flat knit.
Only,
I would say 98% flat knit. Custom. And the companies have great offer there. They're very good products. Yeah.
So garment fitting seems to be such a challenge for these patients. Are there any tips and materials that are better than others?
From the companies I saw who were sponsors of this event, they all have great products. Yeah. Yeah.
Okay.
I wouldn't prefer anything. Yeah. Mm.
So on the clinical aspects, what causes some people with lipedema to develop lipomas as their dominant expression of the disease?
So you mean okay, so even though the names sound similar, lipoma and lipedema, they are completely different phenomena and have nothing to do with each other. There is no overlap. Okay. I myself have a few lipomas on my trunk and they don't bother me, and I don't consider that as a disease. Of course, if a lipoma happens to be in a spot where it causes pain, that's sometimes possible, then it can be removed surgically. But as said, that has nothing to do with lipedema.
Okay. And we touched on this earlier, but several people had asked this question. So can obesity increase lymphedema?
Lipedema or lymphedema?
Lipedema, sorry.
Lipedema, okay. Of course, yeah. That's a very good question. If a patient who is predisposed to accumulate disproportionate fat in the legs, and this patient gains weight, let's say 10, 20, 30 kilograms, she will gain disproportionately in that area. And combined with stress or psychological strain, this can lead to pain being perceived as severe or overwhelming, and that can trigger lipedema or worsen it if it is already present. So yes, obesity has a major impact on the development or progression of lipedema. That's the reason why around 90% of the patients, and all studies say the same. Also the studies from North America, and the colleagues there are not very happy with some of the colleagues there, a small group of colleagues there are not happy with my approach, but also their study, when they speak about their study, said that between 80 and 90% of the patients with lipedema are additional obese. So it's not to say on social media, you always find the question, is it lipedema or obesity? That's a wrong question. In the huge majority, it's lipedema plus obesity. And when the BMI is 35, 45, 55, then I would say it's obesity plus lipedema, because obesity is the disease which in the foreground. I think that's for me, when a woman come to my outpatient department and she has 120, 130 kilogram, and I ask her and say, hello, I'm Dr. Bertsch. How can I help you? What are your complaints? And she comes to me and she said, I'm come because of my lipedema, suffering from lipedema. Then that's similar than when a patient with breast cancer and metastasis of the in the brain and in the liver and in the lung comes to me and says, I would like to speak with you about my cold. You know what I mean? Mm-hmm. Yeah. So obesity is the disease which is in the foreground if the patient has a BMI of 40 and more. And we should treat first the obesity, and then you will see if you treat the obesity, lipedema will benefit as well.
So I'm going to, sorry to jump back, but I just saw a question coming in, and I just want to reiterate on the compression because it's such an important question. So compression therapy will help prevent lipedema from getting worse, correct?
Compression therapy is a pain therapy. What we know is, as I already spoke about the psychological impact, but of course we also have a somatic impact. It's not a pure psychological disease. It's a somatic disease, lipedema. And what we know is that we have a low grade, a very mild and harmless low grade inflammation in the fat tissue. We have good data from Switzerland, from the United States, where we know about that. And what we know is that compression has an impact on this low grade inflammation. So when you have, for example, patients with venous ulcer, without compression, this venous ulcer has no chance to heal. And a little bit similar, not very, but a little bit similar is the effect of compression in lipedema. If there's a low-grade inflammation, you have compression and exercise, and we know both compression plus exercise have a can reduce this low-grade inflammation in the fat tissue, and this has an impact on the pain. The patients experience a pain relief by wearing compression stockings and doing physical activity.
And I just want to reiterate and thank you for the comment. I want to remind people, because we've got people from many different countries, that not only do different countries have different levels or different brands have different names for the compression. So it's a tricky one. Medi and Jobst and some of the others will call something totally different. So when you refer to, I think you said, was it 20 to 30? You said is what you normally use for?
Yeah, that's class 2. Yeah, in Germany it's class 2. In Europe, I know that's between 25 and 30. That's completely enough here, not more.
Yeah. Okay. So what? I'm looking at the time here. Many people were asking about where there's so much confusing information about lipedema. There's so many different camps, so many different practitioners giving different sources of information. Social media you referred to earlier, which is sort of completely out of control with misinformation. A lot of people flock to these sites and try to get their information that way. So you were very kind to put together some good educational materials. Grace will be sending that out to people afterward. So how do you explain those significant discrepancies between the available data and the different schools of thought regarding lipedema? Why are we in this phenomenon where there's sort of two opposing different schools of thought?
Yeah, that's a good question. This I know that particularly in America, it's or in North America, there's a group who is very popular, but particularly among patients, and they have their own agenda about lipedema. They say that it's a edema disease, it's a lymphatic disease. They say it's a low tissue connective disease, and they also published called standard of care. And I believe that's very confusing for health professionals, maybe also for patients who read this, that there's different information. So I would say it's important to really look at the data. Yeah. So serious. You have to look at really what is really serious science, and when there are. May I give you one example? Not sure this is politically correct, but I give you. I don't mention any names, but if you look at this standard of care, for example, and there is one claim is there's lipedema of the abdomen. Yeah, and then this is referred. There's a number that's called 6, and then no one will look at what is really written in 6. Who should prove this claim? Yeah, but when you look at this number 6, you won't find any scientific data that there's lipedema of the abdomen. But people only read there's lipedema of the abdomen, and now I see patients with 150, 180 kilogram with well, severely obese, and they come in my office and say that's not obesity, it's lipedema. So that's really confusing also for the patients, and that's a topic I will speak also at the ILA conference. So I think it's it needs more time, and it needs more energy to really look deeper into this scientific data to distinguish what is really serious science and what is really what is not science. And if you look at the ILA website, there's a lot of good data. We have a lot of studies there. We have a campaign which we will launch at the conference in Niagara Falls. It calls misinformation, and on the ILA website you will all hear this misinformation also from others from Christiana Gordon, from Gabriele Erbarer, all we will speak about the misinformation on lipedema, and you can trust that this information is really science-based and reliable. And maybe a last point, I think social media is also very a problem because they have their own interests. Yeah, that's not a really good source to inform or to get information about lipedema. We start, by the way, one last sentence to this, but because we have a lot of lipedema patients at the Foley Clinic, and they are so full of misinformation that when they come every Saturday, we start these patients when they come every Saturday, we have a 1-hour lecture about misinformation in lipedema. So we try to educate our lipedema patients, which needs a lot of work because all of them have read in the internet about lipedema. And I would say 90% is really not science-based. It's wrong. It's a big issue.
Yeah, and you know, you talk about social media. Obviously, both patients and health professionals, all of us, you know, look at certain things that come up in our feeds based on algorithms that we're, you know, topics, etc., that we're interested in. I see lots of things as well. There is, however, one YouTube video in particular that I know we will send the link to for other people, which is extremely well done. It's not done by a health professional. It's done by a lay person who has, from their perspective, looked at all the research and data. It's a very long video, but I had it on the other day while I was doing other things in my kitchen and listened to it extensively. And I'd encourage people to read that just to get a very balanced view between the two, and then and go from there. I think one challenge that we have is the name. You know, if it's not an edema. Sorry. Yes.
Sorry. And just one comment to this video. Thank you very much that you showed this. This guy is Colin Mockery. He's not a health professional, but he did really a fantastic and very thoroughly research about these two views, and that's very also helpful. Thank you that you mentioned this video. And we saw it, the board of the ILA with Christiana Gordon, Günter Klose, and we all saw this video, and we all were thrilled about this guy, and he did really an amazing job. He did really amazing, and I think it's okay when you start at, let's say, 15, and then you look 1 hour. That's probably enough, and then you have the most important information about this topic. Then you have the view of this North American group, and you have the view of the ILA. That's very good. Thank you very much.
Well, I think it's important to note because it's an objective, sponsored. So not with any company, not with any research, it's not affiliated with your group or any of the groups in the US. It's just an independent patient doing his own research and laying it out very, very well. But the name, I want to finish off by saying the confusing part for so many people is the name itself. When we say there's no edema in lipedema, then why in heaven's well, I know there's a movement starting to try to change that name, because that will, over time, and that's not going to happen overnight either, but over time will help separate out the myth of the edema being part of lipedema. So you can see why the name itself is confusing to people, and changing that will take a long, long time.
Definitely, I agree. But the process has started. We initiated already a publication where many national and international societies have to vote, and they have to make suggestions for a new name. And Wales from UK, Wales already started, very brave. That's Mel Thomas. She's a fantastic person, and she organized it and took over the responsibility. That in Wales it's called lipalgia syndrome, which makes really sense. Lip, fat tissue, algia from pain, and it's a syndrome because there are many other symptoms. So I'm very grateful for Mel Thomas' first step, and I think it's the first step, but others will follow.
Yeah, it's, as I say, it's a long process. It starts with education, information. Things don't change overnight. It's a long process, but everyone showing interest in attending today and listening shows that they have an interest in understanding what the research is behind some of the claims and what they might do, or where they might go for more resources, because we'll include those in the post communications, and where they can learn the resources and what they can pass on to patients as well. We're nearing the end here, and I know there were still one or two questions, but I want to, before I thank Dr. Bertsch for spending so much time, not only for the 1 hour today, but there were many hours before this event, just getting the questions together and rehearsing, etc. And he was very gracious, especially with the time change, doing some of that in the evenings and on weekends with me. And listeners will also have the opportunity to meet and listen to Dr. Bertsch present at the conference this fall in just a month's time. What is the one thing you would want our listeners to take away from this discussion? If there was one thing, what would it be?
You can treat lipedema very well. It's not a dangerous or progressive disease. That's the message for the patients. You can treat really successfully lipedema. And for the health professionals, I would say, don't believe everything what you read from North America. Look at the ILA website and visit the conference in Toronto, not Toronto, in Canada, at Niagara Falls.
Yep.
Niagara Falls, or the conference in Boston from the Harvard University. I think the information you will get there are really science-based.
Great. Wonderful. Well, it's been, I can't believe how fast the hour goes. I think in the very, very beginning, the very first discussion you and I had was, your concern was, how do we fill the hour? And I said, I don't think you need to worry about that. The bigger challenge is there were a lot of questions I didn't get to, a lot of things that other participants would have entered ahead of time. We just couldn't get to them all. But so it probably means another article and pathways in the future next year to address some of these other questions that people might have had, and to outline and share some of the developments since the 2010 consensus, etc. So thank you again for all your time. I hope that now you can relax the rest of the evening. We still have the rest of the day ahead of us, but thanks again, and we'll see you in the fall. See you in 6 weeks.
Thanks, Anna, for having me, and have a good day. Bye, Bonnie. Goodbye. Thank you very much.
I want to thank you both very much for this very insightful and thought-provoking conversation here today, especially for you, Tobias. I know it's getting dark where you are in Germany, so thank you for adding on to your workday to join us here today. I'd also like to just quickly thank someone else. I'm going to surprise her by bringing her on screen. This is the CLF's marketing manager, Grace, who's pulling all the strings behind the scenes and making everything happen here for us. I would be remiss if I didn't also thank our sponsors who help make these programs possible. So thank you once again to Bauer Find, to Juzo, Essity, Medi, Waries, Sigvaris, Lymphology Skincare, and LNR for their very generous support. We're just getting started with Pathways Live. We're very excited to bring more episodes soon. Watch for an announcement in your inbox about our next episode coming up in November. And stay tuned for updates and announcements. We'd love to stay connected. If you have questions or feedback for us, please get in touch anytime. And I just want to thank you for taking time out of your day, our viewers joining us here today to be with us. If you missed any part of it, I know some of you mentioned in the chat that you came in late. We will make a recording available of this for you. And we look forward to seeing you again soon. Thank you again, Anna and Tobias and Grace. Have a great rest of your day.
Bye.
Thank you. Bye.
Bye, everyone.
Bye.